activities that they enjoy. Let's say they like swimming a couple days a week at the pool. Say that makes it go up to about a 6. So a lot of time in the recliner, sometimes falls asleep in the recliner, let's say. Naps in the recliner. And let's say she notices that she's having a hard time. She has a lot of pain when she performs freestyle stroke in her shoulders, let's say, because she has some arthritis. And the only reason I'm giving you that piece of information is because I have to give you something to prompt you to pick one or the other PNF diagonals. So she has thoracolumbar pain and a little bit of shoulder pain, but she's having a hard time swimming. She notices that her arms are a little painful, but they also get tired really easily. So, what would you do for your postural correction?
Chest raise.
There are a lot of different answers.
Yeah.
So she's going to posterior pelvic tilt in a recliner.
The anterior pelvic tilt.
So she could do pelvic tilts, active range of motion, pelvic tilts. Okay. What else? Ooh, and I forgot to tell you, the other thing that a lot of people miss on this exam is in the, this is the number one thing people forget. In this particular exam, and we've done this is the 4th time, and almost nobody does this. In the criteria, the postural correction, it's not just a postural correction. 4 or 2 out of the 6 points, you have to relate the patient's diagnosis to the postural correction. So you have to say, I see that you're rolling your pelvis backward. That puts a lot of strain on your lower back because your pelvis is tilted. It's better if you keep your spine more in a neutral position instead of upright. So you actually have to talk to them about their diagnosis. Say, the reason why you have pain is because you're slumped in your recliner. It might be a good idea to put a pillow behind your lower back or roll up a beach towel and put it in your lower back. I forgot to mention that. I would say, less than a quarter of the class ever does that. I don't know why. But it's there in the criteria. It's just, it's one of these that people overlook more than anything else on this test. Because there's a lot going on, and a lot to remember. So, you could do pelvic tilts. Okay. You could do, someone said you could do
a chest lift
raise.
And tell them that would be important in getting this shoulder to be less hurtful because you're strengthening it out.
That. Say, hey, try to raise your arm up when you're slouched. See how high you can go, and then see how far you can. Now, when you sit up straight, see how much further you can reach. So when you're hitting bad posture, it does influence the way your shoulder joint works. You can do that, sure. But something related to either the thoracic area or the lumbar spine, either do a pelvic tilt or a rib raise would be appropriate. The I don't knows, it's a little bit of a stretch. And the chin tuck, probably not going to accomplish what you need. Something lower would be better. So pelvic tilts, you could talk to her about modifying her recliner too. That would be appropriate. What about for swimming? I'm having pain swimming. What would you do for a PNF diagonal and why?
That would be D2.
I would think so, because you're kind of coming out to abduction most of the time when you're, I don't know, I'm not a swimmer, but
you're not coming into your face.
Yeah, you got it. I would say D2 is probably more appropriate. Again, you can make the argument either way. You could say, well, you really need these muscles, so I would do this, but I would say D2 given how much abduction is involved. You're not really crossing the midline with. Now, if she was doing, say, fly, or if she was doing breast, maybe you could justify doing a D1. But for regular freestyle, I would say D2 would be more appropriate. So you would do that, and come up with some way in 15 seconds or less to explain what PNF is. People did a really good job. I graded all the PNF skill checks. People did a really good job actually saying, this is just a good way for us to train multiple joints at once in your wrist, in your elbow, and your shoulder. People said this is a good way just for your arm to communicate with your nervous system and your brain a little bit better. Just find some way to say it quickly, because otherwise you can get into too much much anatomy and physiology, and it takes away from your time with the patient. Okay, so what else? What could you do? So the other thing I'm just going to encourage you to do right off the bat. Okay. If you're testing someone's trunk flexion, okay, they do the 5, they do the 4, and they do the 3, and they can only do the 3. That's your exercise. Have them work the 3. Say, I want you to do this before you get up out of bed in the morning, and when you lie down to go to bed at night. And I want you to do this. I want you to try to get your shoulder blades all the way off. That's the exercise. Same thing with shoulder. Because remember, to be a 3 out of 5, they have to be able to come all the way up to 90 and hold. If they can't come up to 90, or they can only get to 90 with no resistance, that's your exercise. 1, 2, 3, 4. Active range. Or have them hold something lighter than a pound, probably. Yeah, hold the TV remote. Beautiful. That would be perfect. TV remote. That's great. Here, hold this bone from the bone box. Okay, so for her, if she had 3 out of 5 trunk flexion or extension, you would assess it, and you'd say, this is your exercise. Do that. Just do that there, where you can be successful. That's your exercise. Work that until it gets too easy. Then we'll progress you to the position for a 4, and then we'll progress you to the position for a 5. And for your stretch, I have to give you more information on what was the deficit. Let's say from sitting like this, let's say she had a hard time going into trunk extension, let's say, because her abdominal, her trunk flexors were short and tight from being slouched.
So she lay on her belly, like on her
elbow
press up?
Yeah, sure. You can have her do the press up, sure. You can have her just be on her elbows and do a little stretch.
In standing, I don't know, in standing she could stand and put her hips forward a little bit and
Sure.
walk back.
Is that safe for balance?
Yeah.
Sure. Absolutely.
Get a towel or foam.
Yeah, exactly.
A
Same.
ball.
Yep. You got it. All those are good examples, right? What else? I'm trying to think. Yeah, I mean, that's pretty good. So you'll have multiple joints, easy stretch, easy exercise. But I'm telling you, with the strengthening, this is what we do all the time in our profession. Pick something that they are having a hard time with as part of the MMT, and then just say, okay, good, we've done the assessment now. I'm going to teach you a quick strengthening exercise right there. You're in the position, you've already done it, you've already instructed them on how to do it. They have the the awareness of what they need to be doing, and then you just say, okay, now I want you to do that exercise with that remote control 15 times, sitting up nice and straight. And I want you to do it at the end of every hour-long show, or whatever. I mean, that's too much. But I want you to do it after breakfast, lunch, and dinner 15 times. And if you feel any pain, stop and then wait till after the next meal or something like that. Okay, let's pick another one. Let's say...
On the pelvic tilts, were those done in sitting, or would you instruct them to do that in supine?
It's up to you.
Because since she's in the recliner and already sitting, maybe she'd be more compliant if she didn't have to go do an exercise lying down.
That makes sense. So what she's saying is, you'd probably get her to be more compliant if you could find a way for her to remind herself to do it in the chair. Which would be good, because that would also remind her to check her posture while she's sitting in the recliner watching TV, too.
I just couldn't remember if that was acceptable to start them.
Again, this is one of those questions where I'm really not inclined to take away any points. It's honestly just a matter of figuring out, based on the patient case, what is the best position where they'll be successful? What is safe and appropriate given their strength levels? And, when? When are they ever going to have time to get into supine and do them? If all the other exercises are sitting or standing, it probably makes sense to give them something sitting down. So, but I'm just curious to see what your thoughts are. There's not necessarily a right or wrong answer. There might be a better answer, though.
Instead of doing a tilt, if it's just for posture, can you just instruct them to sit on their sit bones and just
Sure.
like the V, like feel the balance in there.
Tripod, sure, absolutely. Say scoot forward in your recliner and get both feet flat on the ground and roll forward to sit on your sit bones, not on your pockets. Sure. Okay, let's say you had a waitress. Let's say that she was having trouble with two things. She was in a car accident recently. She is having a hard time turning her neck while driving. And she's also having a hard time carrying her tray when she's at work on her left arm. She's left hand dominant, let's say. So, hard time holding the tray, pain and weakness in the shoulder, and having a really hard time turning to look over shoulders when she's driving. Okay? So, everyone's going to be in the same kind of general slouch position. So what are you going to do for your postural correction? For someone who's having a hard time turning and lifting their left arm up.
Chest raise.
Chest raise.
Or idle.
I don't
Idle
know.
nose.
Her head.
Huh?
Her head is messed up. She might need to be put
Sure,
in
you
that
can do. Okay, and then how are you going to relate it to her current diagnosis? You missed that, didn't
It's
you?
putting strain.
So there are 2 points. So 1/3 of the points for the postural correction, you must relate what you're doing for your intervention or postural correction to their current diagnosis. And I was telling the class here that almost nobody ever remembers to do that. It's one small detail that gets lost in all the other things you're trying to manage.
Mm-hmm.
So I was saying, in the case of someone who has low back pain, you have low back pain because you're, sitting in a slump posture that puts a lot of strain on your lower back. If you roll forward into an anterior pelvic tilt or you sit on the tripod, it's going to put your spine in a normal curve. It's going to put less strain on there and you'll have less pain. So for this one, you can do a lot of different things. You're having a hard time turning your neck because you're in bad posture. Feel how far you can go when you're in a slouch position. Now sit up straight. See if you can go a little further. Okay? Because that puts some of your joints and tissues in a better position to enable your neck to turn further. You can talk about how when you're in a slouch position, you're having a hard time lifting your shoulder up because that alters the mechanics of the glenohumeral joint, and how when they sit up straight, they might have a little bit more range of motion through there. And you can talk about a lot of different things. You can talk about how maybe if they sit up straighter, or how they modify their position in the car while they're driving, that might put less strain on the neck and cause them less discomfort when they're turning their head and driving.
That would be adjusting the mirrors thing that Beth said.
Yeah.
Adjust them that way they have to sit up to see through their mirrors.
Good. So what you do is you take your patient out to the car. I've done this a few times. And you say, let's get you in an ideal posture. Let's adjust the height of the seat, the back of the chair, and then let's get you in the best posture possible given your vehicle. Let's adjust the mirrors to that position, and then every time you get in the car, that's where you know you need to be. Don't adjust any of the mirrors, adjust yourself. Okay? So, you're going to do your postural correction. You could do, it should be something higher. It should either be the I don't know, the rib raise, chin tuck, something along those lines. What are you going to do for your stretch?
Could you do the towel and
Okay, now the question is, if I gave you all a towel right now, how quickly could you demonstrate it and instruct the patient? Could you do it in less than 2 minutes?
Yep.
Yes.
We had a long towel. Depends on the cognitive ability of that patient.
Because it's a tricky one, you have to kind of, you have to do the crossover.
You just kind of hold it
Isn't that right? You cross over. I
Yeah,
think.
right.
See, I don't have much of a deficit, so yeah, there you go. So that'll be a perfect one. That's probably your go-to cervical rotation stretch. You could also do something in supine, where you have them, say, lie on a wedge, and have them work on turning and stretch out some of the tight muscles on the contralateral side. What is it? Sure, you can do some active assisted range of motion. Sit up straight, use your other hand, and just gently go over till you feel a stretch. I would be honest, based on my clinical experience, it's going to be probably a little bit safer to do it in supine, I'm thinking, because most patients, when they do it, they kind of go into side bend or rotation, or not rotation, side bend or like extension when they do it. It might be a good idea if you want pure cervical rotation to instruct them in supine. So everything's stable. What about a PNF diagonal? That one should be easy,
D2.
right? I'm having a hard time holding the tray up. Okay? And then what about your strength? Let's say they're weak in cervical extension. Let's say they're weak in shoulder abduction, shoulder flexion. What you do for your, and you assess those. What would you do with it?
Well, you can use a TheraBand for extension, and it can go into for flexion and abduction as well, if they're ready to do that.
So, given the scenario, if it's their dominant hand and they're having a hard time lifting up, I would say that should be a pretty important priority. I mean, the posture will correct their C-spine. The stretch would correct their C-spine. I would want to work on doing some exercises. So, depending on their strength level, if they're a 3, I might have them do something active out to the side. If they're a 4, I might have them do with a lightweight or a TheraBand, yellow maybe. What if they're less than a 3?
Then that's not supposed to be our example.
Well, let's just talk about
Can
what
you
it
do
is.
an isometric against a wall or a table?
Huh?
Or gravity eliminated.
You got it. I like that. Isometric's a good answer. So just remember, so we're on the same page. The patient has to be able to elevate their arm in flexion, scaption, or abduction to 90 to be considered at least a 3. So if they can only go through a partial range, but not get to 90, they're less than a 3. Or you can put them in a gravity eliminated position. There's an alternative way to do it.
If they're less than a 3, can they just try to work on getting to that point?
I would say, as long as they can do it without compensation, in the upper trap or any rotation, absolutely. So, make it easy. I mean, the PNF diagonal should be pretty clear, I hope. We hope. We tried to make it easy for you. The strengthening should be pretty easy. Try to figure out some way to work them in the position that you're testing them. The postural correction, you guys know the basics. Pelvic tilt, I don't know, is rib raise, chin tucks. Pick something that's really easy. And I would say, demo it for them if you can. Show them what you want. And then put your hand on it at least once and say, here, this is what I want you to do. I want you to bring your pelvis forward. I want you to bring it forward. I want you to pinch. And then give them a cue. I want you to pinch through here. Or I want you to come back here. If you can put your hand on, we like that. They need that tactile cueing. And then the stretch is always going to take a little bit more creativity than probably anything else. But remember, we've had people do PNF stretching for their stretch. So instead of giving the patient a stretch, you can do a PNF stretch, and you can say, this is one way that you can work this. You can do this at home. I can teach a family member how to do this with you. It's an option. Good. It's good.
Could you also do a PNF stretch with them and then just have them do a static stretch at home in that same motion?
Sure. Absolutely. You want to see your creativity, of course. Okay, and then let me think of another one. I really like the car accident because it's so easy. Well, let's say you have someone who's 60 years old. Let's say they were out gardening and they have a sloped yard. And let's say they were walking down the hill to get down to their garden, and let's say they fell. Both hands out in front of them, they fell straight down, strained both elbows, both shoulders. Okay? And let's say that shoulders are both 4 out of 5 with almost full range of motion, and let's say the elbows are having a hard time, they're lacking 20 degrees of extension, and they're only able to get to about 95 degrees of flexion.
Did I miss something, you guys? I was reading just somewhere it said we're doing spine, shoulder, joint, and wrist.
Elbow, not wrist.
We're doing elbow, not wrist.
Thoracolumbar, cervicothoracic, shoulder, and elbow. Those are the only 4. Elbow's on there for sure. so I want to give you one with an elbow. Let's talk about it. The elbow is a modified hinge. That's basically what it is. Okay, so shoulders somewhat impaired, but the elbows are more effective. Let's say 3 out of 5 strength in the biceps, and let's say they're having a hard time both flexing and extending. Based on what we went over in lab, what are we going to work on with range of motion? More important.
Flexion.
Extension.
Ooh, that's a good question. So flexion is more important for function. Extension is harder to achieve because we don't go into terminal extension during functional tests very often. So as a therapist who's done this, I'm going to work on trying to gain extension first. Just like I would with the knee, because it's harder to achieve early on. The bending comes from eating every day, brushing your hair, brushing your teeth, putting your clothes on. I mean, the flexion comes, trust me. It's the extension that's much harder to get.
So if you have a patient who's saying that they are having trouble with some sort of ADL, eating, I don't know, grooming themselves, would you still be working on extension first, or would you try to get them to where they can do their ADLs easier
I
and
have
then?
a question that might warp your mind. Why couldn't you do a range of motion exercise, range of motion stretch, gain extension, and then do PNF-D1 to work on gaining flexion?
Oh, okay.
Bam! You just got to be efficient. So let's talk about this. Your staple. I mean, you could do a PNF contractor, but your staple. All right. Well, let's talk about this real fast. If you had an elbow flexion range of motion deficit, what can you do? Boom. That's going to be your go-to. You have patient do self-active assisted range of motion. If they're lacking extension, the classic, I don't think you can ever go wrong with, is a low load, long duration terminal elbow extension stretch. So you should prop the olecranon on something, a towel, a pillow, okay? And then what you should do is have them hold 1 or 2 pounds and have them just work on using gravity to gently stretch the biceps or the joint or whatever it might be out. How long are you going to tell them to do it for?
30 to 90 seconds.
Yeah, at least 30. How many times are they going to do it?
Maybe 2 or 3 times.
Okay, 2 or 3 times. How often?
Twice a day.
Twice a day.
Twice a day. This is a great one for gaining elbow extension. A great one. All you have to do is get something light at home. A soup can, a Coke can. What was the other thing someone said the other day that was great? Someone said like a wrench or a hammer from home, something that's about a pound. You can do almost anything. I've had patients use a rolling pin. I've had patients use, all kinds of stuff. It just depends on what's available, but. So, elbow extension, harder to get early on. I usually do some element of stretching to gain elbow extension. And then for elbow flexion, I love the self-active assisted stretch where you just have them say, okay, now go to the point where you feel mild stretch only. And I want you to hold that. And for me, I'm inclined to say low load, long duration is usually longer than 30 seconds. You'll still get credit if you say 30 seconds, but longer is usually better.
How long is too long for that kind of thing?
That's a good question. And it's hard because it depends on the patient's tolerance. Most people, I would say, agree that if you go longer than 5 minutes, you're probably going to cause a lot of soreness afterwards. Somewhere between 30 seconds and 5 minutes is appropriate as far as I'm concerned for points. So don't underestimate that. And then absolutely pick the D1 to work on flexion. Absolutely. If you want to get flexion and extension, you get them both. And then, for that scenario I just made up, you have them do their stretch with a 2-pound weight, and they're 3 out of 5. Maybe you have them switch to maybe a 1-pound weight or something less than 1 pound. Have them do their bicep curls to work on strengthening. Keep it simple. Boom, you go from a stretch. Okay, now we're going to do our exercise with a small weight. And then you decided your PNF diagonal was D1. And what was the last one? Posture? We talked about that. Something for the cervical spine. So that's kind of the logic behind all of it, is just deciding what the patient needs. And I would say the other thing that you're going to have to really think about, be mindful of having the patient change positions too much. It's another thing that people have a hard time with is they think, oh, I'll do this exercise and this stretch and this postural correction, and you're having them turn. And so that's one thing we like to see. There's a one of the criteria on the grading form is performs interventions in an organized manner. It's worth 5 points, and that's where that 5 points is going to come from this time. Is are you being mindful of how often you're changing the patient's positions? Okay, so I've talked enough. We've got about 40 or so minutes. Let's practice a few things. I want you guys to practice the hand up and get some feedback.